Today in the studio, we have Anna Miller-Fitzwater, and she is a pediatrician, actually, and a clinical consultant with the North Carolina Community Care Network. And we also have Antonio Hedgepeth. He is a quality improvement specialist with the Partnership for Community Care. We'd like to welcome them. Welcome to Public Report, Antonio.
Thank you. Welcome.
Anna, welcome to Public Report. So I guess the first question that I have is, what is the North Carolina Community Care Network?
Sure. The North Carolina Community Care Network is a not-for-profit. It's a physician-led program that manages the state's Medicaid population. We serve about 1,800 primary care practices, 6,000 physicians, and we care manage approximately 1.4 million Medicaid recipients in the state. All 100 counties are covered.
So you're dealing with Medicare patients.
Rather than Medicare, this is Medicaid. So it's the young, so disabled women and children mostly.
Throughout the state of North Carolina?
Throughout the state of North Carolina, yes.
Okay, so what was your role, though, with this program?
Sure. I'm a local pediatrician. I do see patients in the clinic, and part of the basis of community care is to involve local physicians in how to best manage the patients. So I serve as a clinical consultant for our local network, which is the Northwest Community Care Network, serving the Forsyth County and surrounding areas. And I help to facilitate program implementation, evaluation, and provide my opinion on different programs.
Well, that sounds like a big responsibility, actually. Antonio, what is your role with the Community Care Network?
Yes, I serve as a quality improvement specialist for all of Guilford, Rockingham, and Randolph counties. And my main function is to look at ways that we can help practices improve their processes, improve patient care, and improve access to care. So we can do that in a variety of ways, whether that's helping to improve medication adherence or improving their office flow to see their patients in a more timely fashion. That's what we generally help with there. So we look at ways to improve care.
Okay, so now you were mentioning that this is Medicaid. So within Medicaid, you have a variety of patients come from different types or different populations in the community. Is there a specific population that you focus with or you focus on with the Medicaid patients?
Well, not just a specific population.
Okay.
As Anna mentioned, we do look at the age, blind, and disabled. We do look at, primarily our population does involve women and children. Okay. But it can be with any set of chronic diseases and things of that nature. So anything from diabetes to congestive heart failure. We'll look at those. But more importantly, we're involved in an initiative now dealing with foster care children within the state of North Carolina.
Oh, really? Really? So this is a new initiative, and you're dealing now with foster care, children in foster care.
Yes.
So what is the reason for the initiative? That you see that it was a problem with children in foster care having problems with health care?
Yes. As a physician on the ground, I'm a pediatrician, so I see a lot of these patients. The biggest concern I have with the patients is often the patient shows up in my clinic with no medical records. So I don't know if they've had immunizations. I don't know what medications they're on. I don't know what health care they've received in the past. And that's very disabling to a physician to not know how to give the appropriate care. So this program is designed to help that medical history come with the patient, help delineate exactly what adequate responsibilities are in having what we call a medical home for children with foster care, and to help better define what resources these children need, such as cognitive-based therapy, to help improve their care as it goes forward.
So now, when you, with this initiative, are you saying that when a child who's in foster care, they go to the physician, and the physician determines, well, we have no records of this child, we don't know what their past history is. When that happens, what is your role? What does the network do at that point?
Well, some of the things that the network offers, we have a provider portal system that if the child is already with Medicaid, specifically Carolina Access 2, we have an access to some of their medical history, whether that's prescriptions, office visits, as long as it has occurred within the state of North Carolina. And we have other programs that's coming out as well that physicians can sign up for. That's a part of our networks, which is the NCHIE, where they can gain access to those records. Primarily, though, what we try to do, well, my role in this process is to connect the local DSS offices or DHHS offices along with the medical home practices and develop a means by communicating one to another.
Okay. Now, so how are the foster children, how are they benefiting from this program, though?
They're benefiting because when they come to the pediatrician's office, they come with a form that was developed by the state office in conjunction with the North Carolina Pediatric Society that has their medical history, what immunizations they have, what medications they're on. That form comes from the Department of Social Services, to which we have given access to the Medicaid data. So they're coming to the clinic with information, which is new. The first pretense of medicine is do no harm. Well, I don't want to repeat immunizations or repeat other procedures or medications that the child has already had.
Sure.
Or I don't want to miss something. If the child has asthma, for instance, maybe they need a controller medication to keep their asthma symptoms controlled every day. If I don't have that information, then I don't know to give that to them. So they come with information.
So now, because of the foster children, and a lot of them, as you said, they don't have health histories, are you finding that the costs were much higher to treat children that are in foster care?
Well, the cost is higher on average as compared to a child within a normal family setting.
Okay, now why would that cost be higher, though?
Well, the cost is higher because, as Anna was alluding to, the information isn't shared. So without knowing where they are in their preventative care, without knowing if they have chronic conditions, without knowing if they need any high-cost medications, what happens is there's a redundancy of tests and redundancy of procedures being done, which in turn drives up the cost to the overall cost of Medicaid. And so by having the information ahead of time and improving those channels of communication between those who have the child in protective custody, the foster care parents, the medical home providers, and of course social services, it helps reduce the cost overall by knowing what the child has already had in comparison to what they need.
Absolutely, and if a child does not need a shot, they've already had that shot, then we don't want to give that to them a second time if they don't really need that.
And then adding on to that, if we take the example of the child I used with asthma, if you put that child on a chronic medication, it can keep them out of the hospital. It can keep them from having an exacerbation. So if they're on, for instance, an inhaled steroid daily, that can keep them from having to come into the hospital with the associated inpatient cost just by giving a medication every day, which is much cheaper, as you might imagine, than going in the hospital.
Absolutely.
And much less disruptive for the family as well.
Yes, absolutely. But approximately, Anna or Antonia, approximately how many children are you serving that are in the foster care network?
Well, right now we're serving about 75%, and so that turns out to be 7,500 kids that are already in foster care. Throughout the state, I believe the last numbers that were given to us was that there are about 1 million children within the foster care system, and so we're serving about 75% of those.
Okay, that's awesome, though. And so how long do you think that you'll be able to, that it will take to cover the rest of the population, the next maybe 25%?
Well, that timeline, I think, is a little bit higher up than us on that because we are working with less and limited staff.
Gotcha.
And we are still developing and rolling this process out to all 100 counties effectively. And so it's a slow-moving item right now, but over the next couple of years, we anticipate that to continue to grow.
And you're probably in the larger counties, Guilford County, Mecklenburg, Forsyth County, those type of counties?
Yes.
Okay.
It's actually in all 100 counties. It's being rolled out in all 100 counties now. So,
Okay.
Through the different networks.
Awesome, awesome. Now, do you foresee any problems, foresee any problems that the physicians will have when they go to service the children under this new initiative?
I can speak to that.
Okay.
So I think part of the initiative that we haven't addressed yet is defining the expectations of being a medical home for a child with foster care.
Okay.
As you may expect, these visits take a long time.
All right.
And also, we expect that they're going to be seen within a certain amount of time after being taken into custody. So we'd like for them to be seen within 48 to 72 hours. That's a little tough to schedule sometimes, to bring in an hour-long visit in 2 days, to book that on your schedule. Also, there is a piece of physician education about the recommended periodicity schedule for well visits. It's double that. So a normal child you would see, after the age of 3, or you would just see once a year. These children, it's double. We see them every 6 months. So there will be more visits, and that addresses their special health care needs, or the fact they need more care because they have more concerns.
Absolutely, absolutely. And I think it's wonderful that this initiative is assisting the children, but it's also saving the state money. I think that's very important. So taking that into effect, how much has it been determined how much that the state is expecting to save under this new initiative?
We don't have the exact data from that yet, to my knowledge, but we do know that even care managing a regular child saves a certain amount of money, which I don't know exactly, but we do know that it will save money. Do you know anything further, Antonio?
Well, and it's probably a significant amount.
And I think the last numbers that I recall hearing, and this was about a year ago, those foster care kids that are in this type of model, which is the foster care medical home model, on average, it's about $1,500 difference per child.
Wow. Awesome. So now if someone wants to find out more about the North Carolina Community Care Network and what you guys do, I think we're going to post this or show this on the screen for our viewers. Yes, we have it there for our viewers so they can there is a contact number. There actually is a website as well that someone can contact the organization, the Community Care Network, and find out more information. But guys, is there anything else? I know it's gone fast. There's a lot of information to share here. But is there anything else that you guys would like to share about your roles or about the initiative at all?
I think the last thing I would like to share is just the amount of collaboration that this initiative involves.
Okay.
It involves hooking the primary care provider with the Department of Social Services, with the Northwest Community Care Network, with really the North Carolina Pediatric Society. So through this collaboration, it's really a unique program.
Very good, and it sounds like it is, but I'm sure that everybody will actually do their role, everybody will participate, and everything will be great for the children as well as the state of North Carolina. So this has been wonderful information regarding the North Carolina Community Care Network and how it helps, a new initiative for helping foster children. Thank you so very much for joining us.